Okay, dear colleagues, I want to talk with you for some complication in fem-pop interventions and how I deal with them. My disclosures, nothing about this. So I'll show you just one trial, and this is Liberty 360. It's American trial with lots of patients, 1,200. But what is interesting, it's called Liberty because they gave a full liberty to their operators. One of the inclusion criteria was experience in and use of multiple endovascular technologies to treat lower extremity PAD. The other thing is that their arteries of interest is distal from superficial femoral artery, and the Liberty 360 includes all food and drug administration approved technology to treat claudication and CLI. Look at that, that's the devices they can use. As you can see, it's like heaven, everything new. They can use that to treat such patients, PAD patients, but nevertheless, they have some complications. As you can see, significant angiographic complications, 8.5% and nearly 12% in the CLTI patients. So complications are inevitable. As Thanos said, they are inevitable. So the first complication, I will show some of the most popular one, the hematoma or the pseudoaneurysm. You see here beautiful growing hematoma, and this is a pseudoaneurysm after distal puncture. How to deal with that? You can do open surgery, but there are some disadvantages like infection or lymphocyte, but the main advantage is that you can do decompression of the hematoma. You can do ultrasound guided compression, you can do thrombin injection. There are two different types of thrombin injections. You can do it ultrasound guided directly in the aneurysmal sac, in the hematoma, and you can do it endovascularly towards from inside the artery. You can put a microcatheter in the aneurysm or in the hematoma, and when you inflate a balloon inside the artery, you can very safely inject the thrombin in the pseudoaneurysm or the hematoma. The other option is embolization, and the final option is, of course, the stent graft. I want to show you a case with from a colleague, Lafont, who is do it with a closure device with angio seal. What is the point here? You puncture the hematoma. You put a guide wire in the true lumen in the artery, and then you put the angio seal and close the hole with the angio seal. I've done it several times, and I think it's a very good method to close the puncture site when you have such hematomas. The next complication, the most popular one, is the AV fistula. It's usually when you do retrograde puncture, as you can see here, and plain balloon angioplasty, long inflation, is enough to solve this problem. Another case of mine, we chose here directly retrograde approach, popliteal. A patient was in one of my first cases, in prone position, but as you can see, several months ago, we found this AV fistula. Unfortunately, this has to be done surgically. You can put a stent graft, but it's an implant, it's no good. This is operation for 20 minutes, so no problem with closing this AV fistula. Another popular site for AV fistula, as you can see, it's the Brachio Artery. This is a typical case. Look at the artery and the two veins, and here is the Here is the AV fistula. This kind of fistulas are good to be managed surgically. Usually, AV fistulas are self-limited. The other option is prolonged inflation, as I showed you. The other option is using a stent graft, and the final option is surgery, like in this case. Prevention, I strongly recommend usage of ultrasound-guided puncture. Another complication is a vessel rupture. Another patient, hybrid dilatation of the external iliac artery. You can see the retroperitoneal hematoma. Mainly, these complications are from atherectomy devices, from excessive balloon dilatation, when you have extreme calcification, and some of them are guide wire related. This is the definitive AOE study, where they, the study is about the silver hawk, turbo hawk, now it's called hawk 1, and the atherectomy devices, as you can see, the rupture, the perforation is 6.5%. This is another case of ours. You should always know where the tip of your wire is. This is the case. Unfortunately, we didn't see the end of the wire, and we've made a perforation of the side branch. It's the first thing you should do is prolonged inflation, and hopefully this was closed. Again, for vessel ruptures and perforations, the solutions are once more, some of them is self-limited. You can do prolonged inflation, you can do embolization with close mainly, stent grafts, pave and crack technique when you expect such complication, surgery, and maybe usage of image-guided atherectomy like Avenger family, like Panteris, Ocelot, Tiger Eye, and so on. Dissections is the next complication. As you can see, it's always wise to give some time for careful vessel prep. Atherectomy or balloons in increasing diameter, chocolate PTA, serenator auto, or flex vessel prep system, prolonged inflation, of course, and some kind of scaffolds. Distal embolization, this is a case of ours. This is the patient. We're treating the right leg. As you can see, a relatively short occlusion of mid-SFA, but heavily calcified. When we try the recanalization, at the end of it was not successful, but at the end of the procedure, you see that there is distal embolization of the deep femoral artery, and look at the outflow after such embolization. What to do? Surgery, thromboaspiration, manual or WISES, mechanical thrombectomy, different devices, Indigo, Rotarex, angiojet, and so on, PTA, stent graft, or mainly for the prevention is filters and primary stenting. What we did, thrombectomy, mechanical thrombectomy, the deep femoral is okay, but we decided to go on with the recanalization. As you can see, it was impossible to re-enter in true lumen. So I'm a little bit of Scrooge, but sometimes it's wise to use a re-entry device. This is the go-back catheter. With this catheter, you can easily re-enter in the true lumen. As you can see here, this is a command wire. We re-enter, but look at that popliteal artery. We recognize that with O14 wire, but no, nothing can follow this wire. Not a balloon, not a catheter. So I saw this, and what to do? Then we use the same catheter, the go-back catheter, as a crossing device. The needle of the device can create a space for the balloon to come, and it was then easy to put this balloon and make the final arrangements. This is purely PTA, and at the end we put a supera for this calcified lesion. Acute thrombosis, as you can see in this case, 3 stents, but they thrombosed at the end of the procedure, and we have occlusion of the tibial, posterior tibial artery, anterior tibial artery, peroneal artery. What to do? It's the wisest thing to do is WISES or thrombospiration. I prefer WISES. And after 24 hours of WISES, you can see this result. The result is okay with 3-vessel run-off. So much complications. These are the main one, but you can make complication from every device you use. There are some device-related complications and so on, but the take-home message, never mind how experienced the operator is, there will be always some kind of complications. So when performing PVIs, you should be prepared. You have to have a toolbox of devices to deal with, mainly RTPA, different catheters, coils, stent grafts, thrombectomy methods, etc. And if you can't figure it out, don't be afraid to call for help. An extra pair of hands or eyes and a different point of view is always good to have. My final comment is that proper planning, the rule of 5 P's, proper planning prevents poor performance. Thank you for your attention.
Thank you very much.